Thank you. And thanks, Nan, for asking me to do this. I will tell you right away that I am not an expert in any way at teaching. In fact, my other life before medical school was my graduate degree was actually in history, and I taught and ran very quickly away from teaching at that point back to medicine, which is my first love. I don't have any financial or industry relationships to disclose, and as I've just told you, I don't have a lot of education relationships to disclose. So what we're going to talk about this evening is really kind of, in some ways, my evolution as a teacher on the wards. I love medicine. I love what I do, and as I tell my kids every day, it's really not a job to me. It's something that I love to get up and do. And I hope that that's what we can teach our students above and beyond anything. So my rotations are short. As a neurosurgeon, I get the students for 2 weeks at a time. Not a lot of time to impart knowledge on any detailed level. And in some ways, it's challenging to perform any sort of student evaluation. But I think I've learned very well over the last few years a system that works for me. The fundamental challenge for all of us when we're on the wards is really matching what our responsibility is as an educator to what our educational experience is and our skill level as a teacher might be. Most of us come to this in Athens, much like the coach that you see here in this picture. We're coaching our kids the way we were coached when we were in Little League or soccer or gymnastics. What we've learned about coaching or teaching really is what we experienced in our youth. Some of that's really good and some of that's not so good. I think that all of us on the wards really act from a place of meaningful experience, and that's important because we remember our time as interns, as residents, many of us, regardless of how long it might have been ago, as really very vivid times in our lives, some of the best times, some of the most difficult times, but really meaningful. And they shaped us as people, not just as physicians, but as individuals. And as we walk this road with our students, I think none of us would be teaching them if we didn't have confidence in our ability to practice medicine and practice it very well. Most of us teach because we really love our work, and not only do we want to show those students how to be doctors, but we want them to learn how to be happy as physicians, how to find meaning in what they're doing every day. It's not shift work, and it shouldn't be. And lastly, a lot of us teach because we really want good doctors as we get older. I'm 50, and it's looming very quickly. I'm going to see my students looking down at me on a hospital bed one day, and I want to know that that student knows something meaningful. I think one of the first questions we have to ask before we can talk about evaluating a student is, what do we want to teach to that student? We come from a lot of different places. Do we want to teach bedside manner for 2 weeks? Do we want to teach how to take a good history and physical? Do we want to teach how to perform a cranial nerve exam? You have to define what your goal is as a teacher. And then the next thing we do on those 2 weeks with me is figure out, how do we teach? So now I know what information I want you to master, but in 2 weeks, in the clinics, in the operating room, on the wards, how am I going to do that? Medicine at its best traditionally has been taught with the Socratic method. Most of us remember a lot of the Socratic method. We are steeped in it, and it has tremendous value to students, and it's a very rewarding way to teach and a rewarding way to learn. So when we step back and think about how we evaluate the students that spend their time with us, we have to remember every day those two questions. What are we trying to teach, and how am I going to teach that today? Because that also defines not only my time as a teacher, but it defines the student's experience. They really don't have a lot of control over how they're going to see their days and what they're going to have at the end of that day. When I look at my rotation and my time with the students, there's information that I want them to learn. It's a time to gather skills and sets of facts that are going to be important to their patients. I'm not there as a neurosurgeon to teach complicated neurosurgical anatomy. It's just not possible to do in a 2-week period of time. What I want them to understand is basic anatomy. I want them to understand that they need to continue to learn anatomy. So I am more concerned with their leaving my 2 weeks with the ability to go out and learn a specific fact away from me. If they find a problem, I want them to understand how to look for solutions to that problem, how to look at anatomy, how to look at the exam, not necessarily be able to spout back the brachial plexus and draw it out for me, because most of the time they're not going to be able to do that. What I have found is that on those 2-week blocks, the single most important skill I can impart to my students is the ability to understand that what they're learning, what they're memorizing, what they're practicing drawing out before they come to my operating room is important, not because I want them to be able to spout it back, but because what those patients are depending on us for is really a sacred responsibility. And it is as sacred as a medical student as it is as a physician. That patient sits in a chair or lies on a table and gives up all control to us. What better reason to learn, to be able to go out and learn new things every day? That's the most important thing. So that when I sit down and evaluate a student, that's the goal in my mind, and that's what drives all of my evaluation. How effectively can we do this as teachers? Because we really can't evaluate a student with any reliability if we can't look at our own teaching methods and figure out how well we're doing it. I think, yes, I want my students, if I say to you, I want you to come tomorrow and I want you to be able to examine for an L5 radiculopathy, there are certain very basic skills I expect them to go look at, learn, come back, and practice. There is basic information I want them to learn. I need to tell them what I want. We have to communicate very clearly. I want to see them, as those 2 weeks go by, move with those skills from applying a simple set of information by reciting it to be able to look at a new patient and take that information and apply that exam in a new and different way. So I want them to know the information, but I want to watch them next apply that to a patient-centered evaluation. And then I want them to say, that's really great. And how can I apply that? What else does it make me want to learn about? So if I've learned that a foot drop comes with an L5 radiculopathy from a ruptured disc, what else can a foot drop come from? Oh, well, it can be a perineal nerve palsy. Well, let's look at the perineal nerve and figure out, how do I figure the difference between this presentation and the next presentation? How does that relate to diabetes? How does that relate to his body habitus, his work, his activities? That's the ultimate goal for me as a teacher, is to see students really take those facts and make them real, make them important, and make them stimulating. We learn from our teachers. I will tell you that I knew I wanted to be a surgeon within the first month of my medical school clinical rotations. The first clinical rotation I had was with a little Irish nephrologist named Dr. Richard O'Donovan. The intern on the service was about a 6'5" psychiatry intern who loved to walk around the wards at Charity Hospital humming that little Lucky Charms, Frosted Lucky Charms ditty. So he would walk behind Dr. O'Donovan and he would hum this ditty and we would all trail behind him. And then we got to bedside rounds at the end of the week and they were teaching rounds. Now Dr. O'Donovan knew more about these patients at Charity Hospital than I can imagine knowing about my own patients. He stood next to the bed And I can see this to this day. And he looked at me and he said, explain the mechanism of X antihypertensive. And I looked at him and I said, I don't know, Dr. O'Donovan. And I can't do an Irish accent, but if I could. He says, well then, you've not learned very much your first 2 years. Perhaps you should go ask for a tuition refund. And I left and I went home and I said to my roommate, I'm quitting. There's no way I can do this for the next 2 years. And I learned so much on that month's rotation that I went back to him as a senior and did my summer internship in nephrology despite the fact I was going to be a surgeon, because he was just that good. Humiliating, maybe not the best method all the time, but very effective, incredibly good. I fight a little bit of that impulse in my own teaching style because I'm not Dr. O'Donovan. That content that we're talking about really flows back and forth freely between the student and the teacher. So when we're talking about teaching, we've got to make sure that they feel comfortable enough to be able to put that content back to us, to ask questions, to challenge what we're doing, to try to understand all the time why I'm listing certain facts and why they're important. It has to be a two-way street, and that means we really have to communicate effectively. The advice that I got in one of these conferences that has made a tremendous amount of difference to me, and really I think has changed the way I teach students, is I don't internally set my goals. I say at the very beginning, within the first hour of somebody arriving on the wards with me, what do you really want to learn? You've got 2 weeks on neurosurgery. What do you want to learn? What's your goal? And then I tell them very clearly what my goals are. My goals are usually a little bit tailored to what their general interest is, but I want everybody who walks off of the neurosurgical rotation to be able to talk about intracranial pressure, neurosurgical emergencies, and the evaluation of back pain. So I tell them that at the very beginning of those 2 weeks, and then I try every time we see a patient to say, this is what we're talking about. Remember when we talked about. So setting those goals is important, and allowing them to set some goals, I think, is equally as important. Achievement of those goals is really the basis of how we evaluate these students. So how do I grade? Again, by continually going back and touching base again with the students about what the goals were at the beginning of the 2 weeks. I think some of the most difficult aspects of this for me to get my mind around at the beginning is to realize that I'm not really here as a clinical instructor to assess all of the knowledge they've learned over the first 2 years. That's not my job on neurosurgery. That feeds their experience on neurosurgery, but that's really not what my evaluation should be based on. Neurosurgical problem solving, perioperative care, surgical procedures, that's not basic knowledge for a medical student. So I have to step back when I'm doing my grading and realize that, I've been doing lumbar discs for a long time. They shouldn't have the level of knowledge I have. They shouldn't be able to look into a wound and necessarily point to these specific pieces of anatomy that I want them to know. But they should be able to think about it. They should be able to try to reason through some of it. So it's that stepping back from your specialty and remembering what you're really there to evaluate. I give them relevant information. I give them finite groups of facts, finite pieces of the exam, finite surgical procedures that they are to learn about, and then I want them to come back in a defined time frame and tell me about them. I think they need to move from reciting those facts, reciting what the relational anatomy is, to being able to demonstrate it, either on a model or in the operating room, or at the bedside if we're talking about intensive care unit management. And then I want to see them take that and apply it to another problem. I think that this response to ongoing feedback is really important, but again, it's important to remember that that all depends on how effectively I give that feedback. If I'm not particularly clear about what I want or how they've done, they're not going to get any better the next day. I don't give a lot of A's. I'm going to tell you that right now. I think A's are exceptional students. And one of the things that I think we've all kind of gotten used to culturally, and I've got 2 teenage boys, I hated it every time they got a trophy at the end of their baseball season because, yeah, they did a great job, but 9 times out of 10 they weren't winning anything. I don't believe you should give someone an A just because you need to be nice, or you don't want to hurt their feelings, or you don't want to limit their professional advancing. You're there to give an honest evaluation of how they did. So if an A is an exceptional person, we should keep that grade for exceptional students. That doesn't mean that we can't teach toward A's, that we can't continually say, here's how you can be better, let me show you. So what have I learned during this process? That I tend to operate very much, especially at the beginning of this, how I was taught is how I teach. That's not always good. I grew up in a time before our restrictions. I will tell you that when I trained at Charity, for 2 years, I was at the hospital every day at 4 a.m. because I was going to be the best. I was going to be there before the interns, before the residents. That's not necessarily the healthiest thing. Worked out well for me. I wouldn't have done it any other way, but that's not what people are being taught to do nowadays. And in many ways, they're taught not to do that. I learned to change beds with the nurses. I carried the bedpans to the hopper. I ran all the specimens to the lab, and sometimes we ran the machines in the lab, but that was Charity. It's not today. I'm continually reminding myself of that. The other thing that I've found a little bit of a challenge is understanding that their technology, that what they use with their iPads and their phones, it drives me crazy to see them walking around the wards with an iPad because I think that's so distracted. And then I step back and I say, well, they're reading about that last patient. They're going to be able to immediately apply knowledge that they have access to. I couldn't have imagined anything like that, walking around with my ICU handbook in one pocket and my medication guide in the other. What a great gift. So resetting my expectations in terms of how they use their technology has been really important because I was pretty resistant to that at first, to be honest with you. I think these students are hungry for happy doctors who find joy in what they're doing. They hear a lot from doctors who are tired of the system and tired of insurance and they don't get paid enough and malpractice is horrible. That's not what we're here for, and it's really not the majority of what our lives look like. They study on my rotation. They read independently but with guidance. I want them to show a reverence for every patient they see and a reverence for the process of what they're doing in practice of medicine. That's not neurosurgery. It's not, what reflex matches what nerve root. Those are important things, but the broader picture is why are those things important? I'm going to give you, this question was raised to me by a medical student. So it was the end of a long day, and we were doing a carpal tunnel. We weren't doing brain surgery. We weren't really even doing a lumbar disc. But as I'm changing my clothes in the locker room, the medical student comes up to me and asks me, I don't know, is this really worth my while? It's a carpal tunnel release. Do I have to change my clothes for this? She didn't get a really good grade. Kind of violated all those things that I. But in retrospect, I look back at that, and I probably could have had a more constructive answer than, if someone needs their diaper changed, it's worth your while as a medical student, which I really think is true, but perhaps not the most constructive response. Certainly wasn't the most constructive response. But anyway, I just wonder what any of you might say. How would you view that in your evaluation? Because in the end, those are the teaching moments that I think, I hope I'm getting better at harnessing.